The most common repair that we do is on the mitral valve. And most of the time, about 80% of the time, we can repair the mitral valve and don't have to replace it anymore. So traditional open heart surgery involves a sternotomy. That's cutting through the sternum bone, the center of the chest. And then we put the person on the heart-lung machine, the cardiopulmonary bypass machine, in order to change the valve. We do, particularly in our center, a lot of bypass, heart bypass, not cardiopulmonary bypass, but heart bypass operations without the heart-lung machine these days. That's called beating heart surgery or off-pump surgery. And about 80% of the heart bypass operations that we do at St. Joe's, we do without the heart-lung machine. For valve surgery, you can't really do that. You have to stop the heart to be able to cut the valves out. So we always use the heart-lung machine for valve operations. The heart-lung machine and these techniques of replacing the valves, the general techniques, have been in place for almost 30 years and are highly successful.
Is there an age limit on performing
for surgery? Not specific, no. The only real age limits that there are in heart surgery is most of the time, most organ procurement operations won't give a heart transplant to somebody over age 65. But other than a heart transplant, there really isn't any, specific limit to heart surgery. I've operated on a couple of people that were 98, I think, done valve replacements, and they did just fine. In Europe, there are some limits on age limits related to heart surgery, but not here. So heart valve surgery, again, is the most common open heart operation that we do at St. Joe's. In terms of valve replacements, there are more than 250,000 valve replacements a year in this country. And overall mortality is now down in the range of about 2%. So significantly better than it was even just a number of years ago. So I'm going to talk a little bit about how these valves developed. What was it, how did they come together, and what was first done to develop these? In the early 1900s, patients they were able to diagnose insufficiency and stenosis of the valves just by listening. Long before we had an echocardiogram that showed a nice picture and that sort of thing, you could listen to the patient's heart and be able to tell that there was stenosis there. Stenosis was the main reason why people developed cardiac surgery. The valves were blocked and there was a desire to try to relieve that. And the early efforts focused on alleviating the symptoms rather than replacing the valve, because early on in the early 1900s they just didn't have valves to replace them with. And I talked a little bit about the heart-lung machine. So in the 1920s was the first heart operation. It's hard to believe they were actually done in the 20s, but they did. And that was for mitral stenosis, when the mitral valve becomes very calcified and doesn't allow blood through it. The first operation that was developed was dilating a stenotic valve with a finger. So this is the atrial appendage. If you look on the it doesn't show it real well on this picture, but on the picture on the back, on the handout, over on the right side of the paper here, you'll see the left atrium where the pulmonary veins come in there. And in the top, it doesn't really show it on this picture, but on the top of that left atrium, there's a little area that sticks out like this called the atrial appendage. It's like a little ear on the atrium. And so what the first surgeons who did heart surgery was cut a hole in that. Surgeon put their finger in there and then broke through that valve, just cracking the calcium off to allow more blood flow to go through there. That sounds kind of clever, doesn't it? I mean, barbaric in some ways these days, but really clever. And in fact, when I was training, I had 2 senior surgeons who told me they did this in their training. And the patients had relief from mitral stenosis. There was no way to treat it before that. In some patients it actually works. We don't see mitral stenosis a whole lot these days. That's something that's a lot related to rheumatic fever, which we don't see a whole lot anymore either. But there used to be a whole higher prevalence of that. And so this operation was the first real open heart operation that was done related to valves. Dr. Powers was one of the first people who demonstrated that mitral insufficiency caused heart failure. And then over time, the ability to measure the pressures within the heart was then developed. So before that, blood pressure could be measured, but there was no means of measuring the actual pressures inside the heart. And so it was hard to determine what was going on inside the heart other than listening. The other thing that was a really important development in heart surgery is heparin. Heparin is an anticoagulant that we use to keep the blood from clotting so we can operate on the heart. Without keeping the blood from clotting, it's not possible to do any kind of vascular or heart surgery, because when blood is exposed to air, it causes clot. And in order to do any of these manipulations, you need to be able to stop the blood from clotting, do the manipulation, close the heart, and when the blood's no longer exposed to air, and not have clots form everywhere. So heparin is the drug that was developed that allows that. Interestingly, heparin, even still today, is a molecule that is obtained from intestine, from sheep and cow, and sometimes pork. So they actually take the intestines and they do a whole bunch of stuff to it, and they identify this molecule that's in there. That's where it's developed and harvested from even today. So in the 1950s is when heart valves were really first developed. And I'm going to talk a lot about the two different types of valves. Mechanical valves, which is the term we use for a metal valve, and tissue valves, which are valves that come from other animals or people, are the two major different types of valves. Mechanical valves were and still are very durable. Mechanical heart valves that they put in 30 years ago are usually still working today. They don't wear out over time. There have been some refinements. I'm going to show you some pictures here, but most of the time they work forever. The downside of a mechanical valve is if you have a mechanical valve and you need to take Coumadin, blood thinner, every day for the rest of your life. If you ever stop taking Coumadin, there's a very good chance of a stroke and dying from that. So that's mechanical valves. Tissue valves don't require Coumadin. So whether they come from a pig or a cow or a person, they don't require Coumadin anticoagulation, but they can wear out over time. So the same problem that they had in the 1950s when they first developed these valves we have today. People choose between one valve or the other, but there are risks and benefits of both.
Is it true that mechanical valves make a constant noise as well that might be perceivable?
They do make a noise. You can always hear it with a stethoscope. Some patients can hear it and some can't, and you never know who's going to be able to hear it or not. I've had a couple of people who said, that valve, that click just drives me crazy. It's pretty rare for that to happen. Most people say that when they're sleeping at night or falling asleep, they can hear a little bit of a click. And many people say, I can't hear it at all. But it really varies from person to person. But when you're examining somebody who's had a mechanical valve, you always want to hear that click. Because if you don't hear that click of the leaflet, there could be clot there. So that's something that we do watch for. So the first mechanical valve that was developed in the 1950s was by Dr. Hufnagel. This is a ball valve. It's basically just a glass cage here with a rubber ball inside it. It's pretty ingenious at the time, and this was used for a number of years. This was put in, these early valves, in addition to the patient's valve. So they didn't have a way to stop the heart with the heart-lung machine and cut the valve out. They kind of made a quick incision, stuck the thing in there, and sewed it in. It's truly amazing. A valve like this? Is that right? Wow, that's...
Question about rheumatic fever. If you have had it, does it mean you're going to have it attended to sooner or later?
Not necessarily. It's really variable how much damage people get to their heart valves from it. Some have a little bit of a murmur, and other people have their valves destroyed. One or two valves or more destroyed, but it really varies person to person.
Okay.
So the normal valve, this is an aortic valve they're showing here, blood goes perfectly straight through there. It's ingenious design that requires not a lot of eddies and currents and that sort of thing, so it goes straight through there. A ball valve has a lot of turbulence in it, and so they're not as efficient. So a lot of the energy that's coming out of the heart is wasted by moving that ball around. And you'll see as other valves are developed, they become more and more efficient over time. In 1953, Dr. Gibbon performed the first bypass operation, cardiopulmonary bypass operation. And this was the first time that surgeons could actually see inside the heart and operate for longer periods of time, as opposed to just snipping something open and sewing real quick before something bad happens. So 1953 was really the start of modern heart surgery. As valves were developed, they had to address hemodynamics, that's the efficiency of flow, which you saw before. You're going to see some more of those. The durability, there are a number of different valves that have been developed that were more durable than others, and some that we're still using today. And clot is always the problem with anything inside the vascular tree. Clot forming on the valve or clot forming on the sutures, or damage to the blood too. It's not up there as well, but a faulty heart valve can actually damage the blood. In the 1950s, the Starr-Edwards valve was designed. These are still around today. This is a cage here and a ball also. It's a little bit different design. And this was the first time PTFE, which is Gore-Tex, was used, which is still used a lot today in heart surgery because it's pretty durable and it allows us to sew to it. And this had a rubber ball in here as well. That's the original Starr-Edwards valve. This is the more modern version of it, developed in the 1950s, but still sold today. Not a lot of surgeons use this, but some still do. And it's this is a one-piece cage of metal that holds the ball in there, and this is sewn in place. So in the 1960s is the first time orthotopic implants were done, and that is when a valve is placed at the same site of the valve it replaces. That is, as opposed to the early aortic valves where they added in a second valve, actually stopped the heart, cut the valve out, and replaced the valve in its place, which is what we do today. And this was the first time that the patient really depended on the prosthetic valve for survival. The surgeon that trained me at Cornell, Dr. Isom, is one of the pioneers of heart surgery. He's done 6,000 valve operations alone. He told me that when they first started doing these, the mortality rate was 50% when they first started putting in prosthetic aortic valves. Now it's about 1%. So the real difference in a span of 30 years in doing the same operation. The cage disc valve, this is another valve that was developed that's no longer available. It's just got a little disc there that's held in by two metal things. And then in the 1960s is when the Tilton disc valve was developed. This is a mechanical valve that has a metal disc that moves back and forth, and I'm going to show you a video of that. This had better efficiency to it. Again, this is a native valve here, highly efficient, doesn't have a lot of currents and eddies there. And the tilting disc, when it tilts, allows the majority of the blood to flow through freely. When it tilts back, it stops the blood flow. It's just more efficient from a mechanical standpoint. Porcine and bovine, that is pig and cow valves, were then developed over a period of time. And we still use these today. The porcine valves and pig valves is the actual valve from a pig. I'll show you a picture of that also. It's the actual aortic valve from a pig, and they're about the same size as people. We have a whole range of them that we keep on the shelf in the operating room, and they are sized to the annulus of the person. The cow valves, the bovine pericardial valves, are a valve, not the actual valve from a cow. That's too big for use in a human. But what they do is take the lining of the heart, the pericardium of the cow, and then they sew that together in a tri-leaflet fashion to form a valve. There are a couple of different companies that do that. It's pretty ingenious, and they work quite well, and we still use those today. So the advantages of porcine and bovine pericardial valves is it's easily harvested. That is, you can take the lining of a cow pretty easily. They're similar to human heart valves, and all of these tissue valves don't require long-term anticoagulation with Coumadin. Coumadin is a great drug for things like atrial fibrillation. It decreases the stroke rate from 9 or 10% a year to 1% per year. It helps if you have blood clots in your legs. There are a whole bunch of things that Coumadin is a wonderful drug for, including mechanical heart valves. The downside of Coumadin is there's a real risk of bleeding. 1 to 2% per year risk of major bleeding with Coumadin. So that's why if you don't need to take Coumadin, we try to not put you on it, but if you need it, then you have to take it. And that's the question that we wrestle with constantly in cardiac surgery as to what to do with the valves.